Good afternoon, everyone, and welcome to one and all for this Indian Society for Parental Nutrition academic webinar. Um,
Uh, doc,
Okay. Welcome to everyone. Welcome to all who have joined in to hear this academic webinar that we have from the Indian Society of Parental Enteral Nutrition. The society was formed and registered as a society in 1994 at Chennai and is the additional link to the already existing chain consisting of the American Society of Parental Enteral Nutrition, European Society for Parental Enteral Nutrition, the OSPEN, the Australian Society, the Parental Enteral Nutrition Society of Asia, and the SASPEN, that is the South African societies. It's important for all here gathered here to understand that members of ISPEN automatically become life members of PENSA. So, and as a result of this, we are all part of the whole academic journey that all of us have. And without taking much time, I'll invite Ms. Meenal Shah, who is the chief dietitian from Fortis Hospital, for his exciting lecture on how to ensure tube feed tolerance in critically ill patients. Before she starts off, a few housekeeping announcements. If any the end of the entire session. But without much ado, let me hand over the entire talk to Ms. Meenal Shah. Meenal Shah, please go ahead. Thank you very much.
Thank you, sir. A very good afternoon to everyone. So let's move ahead with the topic that we have for the day. Is my screen visible?
Yes, it's visible. No, it's not yet. Not yet. It's yours. It's you yourself, not your screen.
Just a sec, sir. Yes.
Yeah, now it's visible. You can make it full screen. Yes, it's visible. Please go ahead, Meenal. Yeah.
So a very good afternoon to one and all. My topic for today is to ensure the tube feed tolerance in critically ill patients. So when we are planning tube feeds, there are a few questions that we need to understand. So first is how do and when do we start feeding? Once we start feeding, what should we be feeding these patients, how to evaluate the feed tolerance, and how to avoid the intolerances. So when we follow these basic questionnaire, we'll be able to plan the feeds better in order to not land up having intolerance in the first place. So let's start with the first question of when do we start feeding these patients. So the most important thing is the patients have to be hemodynamically stable. Only when the patient is stable, fluid resuscitate, stabilized on declining doses of vasopressin less than 2 vasopressins, enteral feeds can be started and cautiously at low rates. We do not start with full strength enteral feeds on day one or as the first feed that we start for the day. They should be administered in increasing, volume should be increased, and also the energy and protein delivery has to be increased over the next 24 to 48 hours once the patient is stable. But the important point here is to start as soon as possible and not wait when the patient is very stable. Only when the patient is in persistent shock do we avoid enteral feeds. Otherwise, it should be started within the first 24 to 48 hours, because that's considered as the golden window when we need to start building the patient up again. So once we've addressed the question of when, how do we start feeding? What should be the mode of feeding? Now, these patients are critically ill, possibly on ventilators. So we need to be starting with something which is enteral feeds. But when we are planning these enteral feeds, what we need to understand is how well nourished or undernourished is my patient. So when we start with the first 24 to 48 hours, the first thing that we need to do is nutritional assessment of these patients. So I'll be talking about a little more detail further. Once we consider the nutritional support, we need to consider the therapeutic benefits of it, and not just as a therapy or not just because we want to feed the patient. The feeding has to achieve some goals. There has to be some targets when we are feeding these patients. We just don't want to feed the patient with a very small amount of calorie or protein, or not a unplanned venture. It has to be a planned goal where we progress it to the first 72 hours as the full strength feeds gradually. While we are feeding the patients, we need to be keeping an eye on a few things. So the electrolytes have to be very closely monitored. Electrolytes are important when we are planning the feeds. The formula selection depends on the electrolyte. The electrolyte correction has to happen simultaneously. And we also need to look at the refeeding syndrome. So when patients are severely malnourished, these electrolytes, the phosphate and the magnesium, and these are the biochemical parameters that will essentially enable to understand if the patient is landing up in a refeeding syndrome. So that is again an intolerance that we would want to avoid. Also look at the drug nutrient interaction when we are starting the feeds. There are certain feeds, the certain formulas that we need to select based on the drugs that the patient's on. And when tube feeding is considered, like I said, we do not achieve the target on day one of starting the feeds. It has to be achieved slowly and gradually over a period of next 3 days. So we start with minimal of 50 to 60%, gradually increasing to 70 to 100% of the energy requirements of the patient by the third or the fourth day at least. And in certain cases, if EN is not a feasible option, only then can we move to parenteral nutrition. So what we need to understand essentially is early enteral nutrition is very important in order to even cause a metabolic change. So there's decrease in inflammation of the gut or the lung axis, and there's shift towards the anti-inflammatory cytokine response, increasing insulin sensitivity. It reduces gut permeability and supports the compensational gut bacteria, thus increasing the GI motility. So what we need is early feeding. Start within 24 to 48 hours of the feeding, and ensure that the feed is goal oriented and target oriented and not just random feeding that we need to do. Next is, how are we feeding? So if it's an enteral feed, there could be multiple ways of feeding the patients even enterally. So the first and the most basic option that we always choose for is a nasogastric feed. So a nasogastric feed is very easy to put, can be checked with an X-ray very immediately, and we can start feeding as soon as possible. So it's not a very lengthy procedure, and it can be the quickest option that we have. In case of nasogastric, or in case certain cases an orogastric tube is not a feasible option, only then we consider feeding the patient post pyloric, where the RT is pushed beyond the pylorus. And even if that is not a feasible option, then a jejunostomy feeding or a nasojejunal feed would be an feasible option. So there are different indications where the patient is fed post pyloric. Something like, if the patient has the increased risk of aspiration, then the tube is pushed post pyloric. Or in case if there is a increased GRV, the residual volume is high, in that case the post pyloric feeding would land up having some benefits over the nasogastric feeding. And jejunal feeding is considered when there is obstruction, or when the esophagus or the gut cannot be used for feeding, or there is severe vomiting or reflux in that case, or something like where a patient is a case of pancreatitis where we need to give gut rest. That is only period, or a surgical patient where we consider nasojejunal or a jejunostomy feeding. And all of these feedings have a different formula that we need to choose for, and a different mode of feeding. So while we are doing routes of feeding, there could be a patient can be on a bolus feed, where we feed a bolus of 100 or 50. We start with normally a 50 volume, and then increase it to 50 or 100 or 150, depending on the patient's fluid requirements and energy requirements at the same time. But if it's a jejunal feed, or if the patient has severe risk of aspiration, or the patient has a high GRV, in that case, a continuous feed is what we normally opt for. So when we are talking about continuous feeding, a patient is started with a tropic feed of, let's say, 10 to 20 ml of drip per hour, which is then gradually increased to 50 or 75, depending on the patient's requirements again. The advantage here being that it is a slow drip. The risk of aspiration, or the risk of increased GRV or abdominal pain or distension reduces, since we are going in a slow drip method and not a bolus volume. In certain cases, even case of severe diarrhea, we would end up having a continuous drip feed over a bolus feed, again for the same reason, that improves the tolerance of the feed. So a continuous drip feed with a proper infusion is what is normally recommended when the patient is very critically ill, and then wean off the patient to a bolus feed eventually once the patient's tolerance to feeds increases. So hence we have addressed the formula feeds, what needs to be fed. So we have had started the feeding the patient, we know the mode of feeding, we know the route of feeding. What should be fed to these patients? So by the recent researches that we have had over the years, scientific formula feeds are considered to be best for the patients who are critically ill. Reason being that it is one precise. You know clearly what is the amount of calorie and protein that you're feeding these patients. At the same time, since it's prepared at the bedside, or prepared in a very isolated area, the risk of contamination is bare minimal. Whereas compared to the earlier trend where we used to give kitchen feeds or blenderized feeds, the risk of contamination was quite high, and the delivery of nutrients is always questionable, because that's something which is very manual and may change depending on the person who makes it, even if they're trained. Also, when we are opting for some scientific formula feeds, we can ensure that the requirements of the patients are very clearly met. And it is, we can always offer different formula feeds, so we can have something like a ready to hand feed where it is very neutral and sterile, and the patients who are very critically ill or in case of neutropenia, these feeds become a very good option for them. If it's a formula feed where we have water reconstitute powders, even in that case the contamination risk is very less as compared to the blenderized feed. And hygienic preparation of these feeds at the bedside or by trained staff kind of makes it easier for the monitoring as well. So if it's a tin that we are supposed to ensure that the patient is supposed to be fed X number of scoops throughout the day, it is very easy to monitor these containers and to ensure that what is written on the plan, the calorie and protein delivery, is ensured to the patient. So it's not just a plan on paper, it's actually what is delivered to the patient, which can be very closely monitored. So a formula feed is any day better than a blenderized feed, especially in the critically ill patients. Now, how much do we feed? So everything else is sorted. Now, how much do we feed this patient? Now, feeding the energy, the amount of nutrients that we need to feed the patients is very closely going to be dependent on the patient's nutritional status. So the first and the foremost thing that we look at is going to be the patient's assessment, a nutritional screening and assessment that needs to be done by a validated tool. And SGS is a very good research tool that can be used, or a tool which is similar to an SGA, or based on an SGA tool can be a good assessment tool that we start with. Once we have screened and assessed the patient's daily requirements needs to be calculated, and it has to be done by a very well trained dietitian or a very well trained ICU staff. So whenever possible, in case if we can do a further thorough assessment, because the assessment tools are based on the patient's height, weight, and the patient's history of food intake. If we want to look at the patient's actual physiology, the lean body mass or the bone weight, then a CT or an ultrasonography would be a good option. The only thing that is we need one CT has to be a part of the procedure, or it's a cost in the cost venture. And in case of an USD, it has to be done by a trained person. So training is something that we need to look at. And once we have done the assessment, we need to coordinate with the intensivist as well, because based on the nutritional score of the patient, would the further plan of action be determined. So it has to be done like a joint venture with the intensivist, the nursing, and the nutritionist to ensure that what is being planned, calculated, has been met. Now, estimating the energy and protein requirements. Now, the feed has to be tailor made as per the patient's requirements and the patient's level of tolerance. We cannot just plan a feed and believe that that is what's best for the patient and just leave it to be. Once we have started a certain feed, it has to be monitored for tolerance. So, in case of intolerance, there may be times where we have to step down a little, or in case if once tolerated feeds have been very well tolerated, do we step up the feeds to a further plan? So we may start with 70 and progress to 100 if the patient's tolerance is good. But if in case the patient's tolerance is not good, we might have to come down to 50 and to wait for further assessment. Also, the energy and protein requirements have been described by a lot of guidelines, ISPEN guidelines included in it, stating it should be anywhere between 1.2 to 2 gram per kg of the present body weight, and the calories for a critically ill patient has to be between 25 to 30 kilocal of the present body weight. Now, in certain obese patients where the weight is more than BMI is more than 30, it would be best to calculate the energy requirements based on the adjusted body weight. The formula being adjusted body weight minus idle body weight into 1.0.33 plus the idle body weight. So here it gives us a fair idea, because meeting requirements of an obese patient becomes very quite difficult, and it may not be needed in the first place. In severe catabolic patients such as extensive burns or polytrauma, the ratio of calories to nitrogen ratio should be 120, but it can be dropped down further to 100 because they have extensively high energy requirements. For these patients, the energy and protein requirements can be stepped up to 35 to 40 kilocal per kg present body weight, and proteins can be as high as 1.2 to 2.5 to 3 grams per kg depending on the severity of their burns. Harris Benedict tool has been considered as a good tool for assessing the energy requirements of patients, but the only problem with Harris Benedict, it's a time consuming and a long procedure. So when we want to be quick and we want to ensure that the patient's feeds have to be met, then these ESPEN guidelines and any good reliable guidelines would help us out with a body weight based calculations rather than extensive formulas. So once we have estimated the energy and protein requirements, we need to choose a certain formula for them. So like we discussed, formula feeds are what should be considered for critically ill patients and not commercial and not kitchen feeds. But standard polymeric formulas are of various types that we get. So what can be done is standard polymeric formulas have to be selected based on the patient's requirement. In case if the patient is critically ill, or the patient has a gut condition, or there are patient has intolerances, it would be best advised to start with partially hydrolyzed formulas and then step the patient up to a complete formula, complete protein formula by day 2 or day 3 based on the patient's tolerance. We also need to look at the electrolytes of these patients. If the patient is hyperkalemic, or if the patient is in a state of hypernatremia, then a formula has to be carefully selected, which according to the patient's requirement of that period. So the formula feeds have to be carefully selected, and it is also based on the patient's route of feeding. The In case if the patient is on a gastro feed, we can always start with the complete formula, complete protein formula, a standard polymeric formula that we have in the market. But in case if the patient's on jejunal feeds, the best thing would be to start with peptides. So based on the location, the if it's a nasogastric or jejunum or a jejunostomy feed, is how we choose the formula. And avoid also while choosing the formula, what is important is looking at the dilution. So we can't be giving not be looking at the dilution when we are administering this formula. The feeds have to be planned in such a way that the feeds are not too osmotic. So either follow this, best thing would be to follow the standard dilutions that we have. So that ensures that the feeds are well tolerated and not osmotic, thus avoiding intolerances in these patients. And normally we don't use specialty formulas because critically ill patients are have multiple complications together. So we're not going to be dealing with just a liver patient or a just a kidney failure patient when in ICU. There would be more than those cases, and it would be best to have a wholesome formula rather than having a disease condition specific formula while planning these enteral feeds. So permissible underfeeding. So how do we manage the calories and protein? So there's a common consensus that overfeeding should be avoided, especially in the acute phases when the patient is just been started on RT feeds, or just started with in the ICU. It started with enteral feeds within 24 hours. Patient is going to be in an acute phase, so it is very difficult. It should not be patient should not be overfed in these cases in the initial phases. Best thing would be to target the full energy requirements of these patients over the period of next 3 days. It would be best to start with a low calorie formula, start with 70% of the targets, and then move on to the full strength of the feeds by third or the fourth day, depending on the tolerance. That's the best thing to avoid overfeeding. It is also important that we do not underfeed the patient while trying to do that, because giving less than 50% of the formula would be no achievement is done out of it. So when we are planning a feed, it has to be planned in such a way that we start with 50 or 70% of the requirement and then progress on, and not less than that. Otherwise there's no point in feeding the patient. So according to last observational studies, it has been observed that the optimal calorie load is associated with 80% of the energy requirements. Too low or too high increases the mortality of the patient. While we are feeding the patients and while we are keeping an eye on the energy and protein requirements of these patients, the micronutrient requirements also need to be addressed. So if the patient is coming with severe malnutrition, or patient has been not eating well, then there could be pre-existing micronutrient deficiencies which should be evaluated and assessed once the patient's been admitted. Also, these micronutrient deficiencies would increase the risk of your patient in terms of there could be decreased immunity, compromised wound healing, increased mortality and morbidity. All of it because the patient was deficient in the trace elements. So the best thing to do would be to start with multivitamins for these patients. It can be specific multivitamins like zinc for wound healing, or a wholesome one complete correction of multivitamins to ensure that all the requirements have been met. Now, most of these micronutrients are also a part of the blender, or also a part of the formula feeds that we have. So we need to keep a check of what formula are we using and what requirements are not being met. It has to be supplemented, especially when the patients are on blenderized feeds or on parenteral nutrition. Important point that we would consider is the serum phosphate level. So phosphate is one of the major indicators that we keep an eye on, especially when we are dealing with the refeeding syndrome. So that's a good indicator that we would want to get assessed if the patient is coming with malnutrition, and get it checked, get it corrected when we are starting with feed, so that we do not cause an intolerance in the patient. Now, once we've started feeds, evaluated and everything, how do we evaluate if the feeds have been tolerated well or not? So there are three modes of mechanism of tolerate checking the tolerance of the patient's feed. One is the gastric residual volume. So the gastric residual volume is measured by aspiration. More than 300 is something where less than 300 is where we can actually refeed there. More than 500 of the GRV is where we would want to hold a feed and check in case if the patient has a risk of aspiration. So what can be done is, once we start feeding, patient can be checked for aspiration after 4 hours. In case if the GRV is not much, continue feeding the patient. In case if you've had a GRV of more than 500, in that case, we want to avoid feeding the patient for the next feed and reevaluate after 2 hours or 4 hours and see if the patient has tolerance. In case if the patient has continuous high GRV, you'd want to look at the mode of feeding or the volume of feeding again. So reduce the volume of feed and see for check for signs of intolerance. Or what can be done is patient can be switched to a continuous drip feed and see if that works better. So prokinetic agents are another factor that we can be added to in order to increase the gut motility. So that is something again which can be looked at. Nurses have to be trained well to in order to check these signs of tolerance. They may call that the patient is aspirating, but the aspirate may not be more than 20 or 50. So they need to be explained and trained in a very clear manner of what is the amount that we would want to be raising red flags about. Second thing that we would want to do is look diarrhea. That is one of the most common complication that we would have when we're dealing with patients. So when we are talking about diarrhea, uh, we would normally look at the enteral feeds as a cause of diarrhea, but that may not be the case. So, most importantly, whenever the patient lands up having diarrhea, please do not stop enteral feeds. We need to continue feeding the patients even in presence of diarrhea, but re-evaluate what is the cause of diarrhea. So, feeds can be looked at in terms of the osmotic load of the feeds. Also, in case if most of the formula feeds that we get in the market are lactose free, but still look at the lactose content of the feeds if that's one of the aggravating factors. Antibiotics could be one of the major reasons why the patient is having diarrhea. It could be the basic physiology of the patient where the patient is just not tolerating the feeds. But in any case, reevaluate the feeds. In case if everything else has been ruled out, if the feeds are not osmotic, if the feeds where patient is being checked for C. diff infection, even if that is clear, add soluble fiber to the feeds as a first mode of mechanism so that the patient would, it helps reduce the diarrhea. In case if that is not working, we can change the feeds to a peptide formulation so that it's easier to digest and it reduces the load of the gut. But if even that doesn't work, you can look at probiotics. Probiotics is something that we need to discuss with the intensive team as well, because there may be certain indications where it may not be allowed. So, as per discussions with the intensive team, make a joint decision, but continue feeding the patients, because not feeding the patient is not going to help resolve the diarrhea. Next, the refeeding syndrome. So the refeeding syndrome was another part that we need to look at as one of the major signs of intolerance. So if the patient has come in with severe malnutrition and patient has not been fed for a longer period of time, then the refeeding syndrome is something we need to keep an eye on. So there are certain criteria established to indicate that the person may land up in a refeeding syndrome. So either the patient has one of more of the following criteria as listed here: a BMI of less than 16, unintentional weight loss of more than 15% in the last 3 to 6 months, a little or no nutritional intake for more than 10 days, and a low level of potassium or phosphate or magnesium before feeding. Or the patient may have two or more of the following symptoms, following indications: BMI of less than 18.5, unintentional weight loss of more than 10% in the last 3 to 6 months, little or no nutrition for the last 5 days, and a history of alcohol misuse or drug misuse, or including insulin, chemotherapy, drugs, antacids, or diuretics. So these are the areas where I would want to keep an eye on if the patient may land up in refeeding syndrome. So what happens in refeeding syndrome is when we start feeding the syndrome, there is a complete shift in the fluids and the electrolytes, and the patient will land up having hypokalemia, hypomagnesemia, hypophosphatemia, and thiamine deficiency. And the best way to treat the refeeding syndrome is correction. So when we know the patient is at risk, we would want to keep an eye on the potassium, calcium, phosphate, and magnesium. Before starting the feeds, administer doctor would normally administer thiamine, would look at the B12 levels. And once their multivitamin correction has been in place, once the phosphate also has been placed, simultaneously start feeding on a very slow content. And once we start feeding, keep an eye on the levels as well. There may be cases where the patients may have had a good phosphate initially, but then once you start feeding the patients, the levels drop. So it would be best and advisable to keep checking the phosphates after a few days and accordingly make corrections as per the requirements, and increase the feeds gradually. You may not want to start with even 50% or 70% of the feeding requirements for these patients. We may go very gradually. It may be as low as 500 calories initially, and then stepping it up to as per the patient's tolerance, to meet the full requirements of the patient. So refeeding is something which needs to be very closely monitored, and not just with the intensivist but also with the endocrinologist and the dietitian, so that the planning is in such a way that it does not cause intolerance in patients. All of it has to be very carefully and tediously documented. That's a very important point, because in case if there is any intolerance that we've seen in a patient, documentation is the best step that will help us identify if there was a change. So the documentation of the medications, documentation of change in volume, documentation of change in the energy and the protein delivery in the file kind of helps us trace back the intolerances, what went wrong or what changed which caused an intolerance. And whenever patient ends up having any change in the biochemical parameters or any change in the feed volume, everything has to be documented in the file, and the feeding plans obviously have to be part of the file, so that even the intensivist and anybody who looks at the consultants or anybody who looks at the plan are very clear on what is the amount of calorie protein which has been recommended, how is the delivery happening, and how do we step it up further. So the step up plan has to be in accordance of the patient's tolerance, and like I said, all of it has to be very clearly documented for us to trace back in case if there's a hiccup that we have. Overall, we would want to put on a few more preventive actions of routinely flushing the tube with sterile water so there is no blockage, checking the feed tube placement, so that we are ensuring that the feed is at the right place, keeping the bed elevated of 30 to 45 degrees Celsius, using aseptic techniques. The feeds had to be cleaned thoroughly, which means it has to be flushed after every feed, so ensuring that the fluid it is not blocked. Document everything in the medical record, prevent contamination, maintaining safe hang time. So even that's an important factor, where sometimes the feeds may be hung for a very longer period of time, making a larger volume, which is not okay. The hang time should not be more than 6 hours for best results. Ensuring clean hands, work surfaces have to be clean. Do not add medications to the formula directly. The medications and formula have to be administered separately, and the feed has to be tube has to be flushed with water when in between of these things. These are a few more steps that helps us to ensure that the feeds are given correctly. And these are a few references of what we have done today. Thank you,
Yeah,
everyone.
thank you, Dr. Meenal. And Meenal, it's been as Ispen puts it, we would probably keep academic on the forefront. Thank you, Meenal, for this lecture. And I think what Meenal you've done is you've gone through each and every aspect of how we should look at critical care on a general perspective. And this lecture would probably be a great lecture for us as doctors whenever we're going for exams. Um, well, everyone eats. Making diet is one of the most common exposures possibly influencing health and disease outcomes. I think diet is something that is commonly done for all patients. But the
Yes.
research in nutrition is actually very complicated. There are numerous factors that are inherent in this area of inquiry. In fact, nutrition with its myriad health implications, it's an exciting, challenging, and ever evolving area of research. Um, and that's why I think we need to meet more often to actually discuss across a table on a webinar to understand more about this aspect. And one of these aspects that also is very difficult is assessment of malnutrition. I mean, we've been looking at assessment of malnutrition for a while. I mean, right from the time of Harris Benedict to SGA to whatever comes off new, we are still not able to really assess malnutrition like the way it should be, and we still are griping with new and new definitions. I think we've got more than 200 definitions of malnutrition, and we still aren't able to define this or assess this as well. So to take us through this, I would invite Dr. Rajeshri, who is the head of clinical dietetics and nutrition at the SL Raheja Hospital. And without much delay, Rajeshri, please take over the screen so that we can actually hear from you. Dr. Rajeshri,
Yes.
you. Can we share the screen? Rashi, we can see your screen. You can start. I mean, just make it full screen first.
Yeah.
Yes, please.
So my talk today is assessment of malnutrition in ICU. I will be discussing the phases of critical illness, the factors associated with malnutrition, impact of malnutrition in critically ill patients, the diagnosis of malnutrition, what are the guideline recommendations for nutritional screening and assessment, what are the different assessment tools, I'll be going through them, and lastly the conclusion. So as you see, this malnutrition is globally prevalent in most of the ICU patients. It varies from 38 to 78%. And in India, 2/5 of the patients admitted in tertiary care hospitals are malnourished. So how do you define critical illness? It is associated with the catabolic stress state in which the patients they demonstrate a systemic inflammatory risk coupled with complications like of increased infections. Then there is multiple organ dysfunction and long hospital stay and disproportionate mortality. So I think you're familiar with the acute and the late phase of the critical illness following injury. In the early period, in the acute phase, there is metabolic instability and there is a severe increase in catabolism, whereas the acute phase is in the early periods from day 1 to day 2. The late period, which is usually from day 3 to day 7, there is muscle wasting and stabilization of the metabolic disturbances, and then there is improvement and rehabilitation or persistent inflammatory or catabolic state and prolonged hospitalization. This is a chronic phase. So I would just like to describe the pathophysiology of the this malnutrition. That is, whenever a patient is critically ill, there is a release of inflammatory mediators. The pro-inflammatory mediators like IL-1, IL-6, and TNF, this tumor necrosis factor. And at the same time, this catabolic hormones are also released like glucagon, cortisol, and catecholamines, which generate the endogenous energy substrate like glucose, amino acids, and fatty acids. At the same time, the body this produces an anti-inflammatory response. So there are anti-inflammatory mediators also. But the thing is that both of them need to be in balance. Like if this anti-inflammatory mediators which are produced by the body in response, if it is more, then this it results in a sort of paralysis, and if in order to correct the balance, if proper nutrition is given, the nutritional therapy is given, then it improves the nutritional status, and it helps to correct the malnutrition. It helps to preserve the body mass, and it also lastly improves the nutritional status. So as you see that malnutrition is classified like whenever a patient is chronically ill, or if he's having malabsorption, or he's not been fed for a long time, then there is an inflammatory response resulting in stress-related catabolism, and which results in frequent infection, altered intestinal function. There is delayed wound healing, and there is impaired immune function. So, what are the factors associated with malnutrition in critically ill patients? Is basically that many of them they have increased dependency on mechanical ventilation. The length of hospital stay is increased, and these sort of patients, you see them coming, getting readmitted to the ICU time and again. The rate of infection increases, and there is also a risk of hospital mortality. The mechanism of malnutrition, particularly ill patients, is there is stress and injury. Again, I think I've already covered that, and which leads to induction of anorexia and catabolism. So, what is the impact of malnutrition? It results in poor wound healing. Then there is weakness. You see, like day in and day out, means when you're visiting the patient daily, you see the patient becoming weak. He's not able to, he's not mobile, and he's not able to do proper physiotherapy. Then there is decreased ventilatory drag and increased duration of ventilation. There is muscle wasting due to protein catabolism, and mucosal atrophy is there, and there is apathy and depression also. So then we come to the diagnosis of malnutrition. There have been many definitions for malnutrition, and next we move on to how we proceed for the assessment. That is, first we do the nutritional risk screening. followed by the nutritional assessment and the diagnosis of malnutrition and in establishment of individual nutrition targets. So, as per the this ISPEN, it indicates that nutrition risk should be performed on all patients admitted to the ICU, for whom the intake is anticipated to be insufficient, and mostly the common ones which are used is NRS 2002 and Nutri-Score. Like there are many nutritional tools, but these are more important and more feasible in the ICU for critically ill patients. In Aspen states that the general clinical assessment should be performed to assess malnutrition in the ICU, and the clinical assessment parameters include this unintentional weight loss or decrease in physical performance before the ICU admission. That is when we assess the patient. We do ask for these questions. We physically examine the doctors physically examine the patient. There's general assessment of body composition, muscle mass, and strength using different using dynamometers. Then in Indian guidelines, it states that all the critically ill patients should undergo nutritional assessment on admission. Nutritional status of the Indian malnourished patients can be assessed by the subjective local assessment. So we move on to the nutritional screening tools. That is the rapid and simple evaluation. It takes into account the recent weight loss and the recent food intake, like maybe previous 1 or 2 days or previous week or something, the current BMI and the disease severity. So if we compare the two, NRS 2000, the two screening tools, that is NRS 2002 and the Nutri-Score. The NRS 2002, the components are that the weight loss should be greater than 5%, recent food intake compared with prior of 1 week, BMI, disease severity, and the age greater than 70 years. Whereas in Nutri-Score, it is age, Apache 2, SOFA, comorbidities, and days from hospital to ICU admission, and IL-6. However, many don't include the IL-6 if unavailable. And the steps is for NRS 2002, it's a single scoring system. For Nutri-Score, it's a 4-question screen followed by the scoring system if positive. Score range is 0 to 7, and in Nutri-Score, it is 0 to 10. Interpretation is for NRS 2002 is if it is less than 3, then it is no risk. If it is greater than or equal to 3, then the patient is at risk. In case of Nutri-Score, if the score is less than 6, it is low malnutrition risk. If it is greater than or equal to 6, then the patient is at risk. This is the NRS tool. So the basic 4 questions which are asked is in the initial screening is the BMI less than 20.5? Has the patient lost weight within the last 3 months? And has the patient reduced dietary intake in the last week, or is the patient severely ill? So if the answer is yes to any question, then the screening for the table 2 is performed. And if the answer is no to all the questions, then the patient is re-screened at weekly intervals. And if the patient is scheduled for maybe a major operation or something, preventive nutritional care plan is considered to avoid associated risk status. Now, when we do the final screening, if the score is 0, then it is a normal nutritional status. If there is a score is 1, that is a weight loss of greater than 5% in 3 months, or if the food intake is below 50 to 75%, the normal requirement in the preceding week. If the score is 2, that means it shows moderate this impaired nutritional status. That is, a weight loss is greater than 5% in 2 months, or BMI is between 18.5 to 20.5. Plus, there is impaired general condition, or the food intake is 25 to 60%. If in case of severe malnutrition, the score is 3. The weight loss is greater than 5% in 1 month, greater than 15% in 3 months, or the BMI is less than 18.5 plus impaired general condition, or the food intake is between 0 to 25% of normal requirement in preceding week. In case of the severity of disease, if the score is 0, then you can give normal nutritional requirements. If the score is 1, that is which indicates mild malnutrition, that is in case of this hip fracture. So in these kind of patients, you can see that the score is 1 usually. In case of this major abdominal surgery, stroke or severe pneumonia, it shows moderate malnutrition, and in severe malnutrition is seen in case of patients with head injury and bone marrow transplantation and intensive care patients. So if we see that, I think this I've already covered. Yeah. So the score is impaired nutritional status plus the score of the severity of the disease, that is the total score. And the age adjustment is if the patient is 70 years or more than that, then one is added to the total score. This is the Nutrix score. So it covers all these variables, that is age, Apache 2, SOFA, number of comorbidities, stays from hospital to ICU admission, and IL-6. And the Nutrix scoring system, if IL-6 is available is 6 to 10, that is a high score, is associated with worse clinical outcomes, that is mortality or ventilation. If it is 0 to 5, then a low score, these patients have a low malnutrition risk. And if no IL-6 is available, the score, if it is 5 to 9, then it is a high score. It is associated with worse clinical outcomes like mortality or ventilation. If it is 0 to 4, then it is a low score. These patients have a low malnutrition risk. So basically, the this assessment should provide a picture of the patient's current nutritional risk, and it involves history, physical examination, anthropometric measurements, and biochemical data. But let me tell you that there is no single test or say measurement which can provide enough information to assess a patient's nutritional status adequately. So I would just like to state that common malnutrition screening tools are inappropriate in ICU. So the only which can be used is NRS 2002 and the Nutrix score. The anthropometric measurements such as triceps, skin fold thickness, and mid-arm circumference may be obscured by fluid shift or edema, and voluntary hand grip strength is impractical in unconscious, sedated, and ventilated patients. So for these kind of patients, we cannot take the hand grip strength. And biochemical markers like albumin or other proteins with a short half-life, like transferrin, are acute phase reactants, and they are frequently altered in critical illness, so we cannot consider them. Other laboratory measures like lymphocyte count, skin prick test, reactivity are abnormal in critical illness. Next, we come to the GLIM criteria. It has phenotypic and etiological criteria for the diagnosis of malnutrition. So this phenotypic criteria includes the weight loss that is greater than 5% within past 6 months, or greater than 10% beyond 6 months. Low body mass index, that is less than 20 if the patient is less than 70 years, or less than 22 if the patient is greater than 70 years. Reduced muscle mass, reduced by validated body composition measuring techniques. And in case of Asia, it is less than 18.5 if the patient is less than 70 years, or less than 20 if greater than 70 years. Etiological criteria is reduced food intake or assimilation, that is if less than 50% intake, or any reduction for greater than 2 weeks, or any chronic GI condition that adversely impacts the assimilation or absorption. And in case of inflammation, that is acute disease or injury or chronic disease related. So if one phenotypic criteria and one etiologic criteria is if the patient is there, means if he has one phenotypic criteria and one etiologic criteria, then it indicates that the patient is malnourished. To diagnose malnutrition, at least one phenotypic criteria and one etiologic criteria should be present. So phenotypic metrics for grading severity are proposed, and it is recommended that the etiologic criteria be used to guide intervention and anticipated outcomes. Now, we move on to the subjective global assessment. This is usually performed by the dietitian, and it usually covers, like a series of questions. Like the dietitian asks a series of questions to the patient or the relative, and many a times it is not possible. If the patient is sedated, then they have to ask the relative. So weight changes, and then this dietary intake in past 1 or 2 days, or maybe previous 1 week or something, any GI related symptoms like nausea, vomiting, loose motions, or anything. And the functional capacity of the patient, that is whether the patient is able to move about, or is he in a wheelchair, or is he bedridden, and disease and its relation to nutrition requirements. Features of physical examination include muscle wasting, and ankle edema, or ascites. Based on the features, the patients are classified as well nourished, when they fall into the category of moderate malnutrition or they are suspected of malnutrition, and the third is the severe malnutrition. So if we categorize the stage A is the well-nourished patients, the stage B is the moderately malnourished or suspected malnutrition, and the stage C is severely malnourished. Now, in case of well-nourished patients, as you very well see, there is no weight loss or there is no deficit in nutritional intake, and the patients are mobile and there's no deficit or significant recent improvement. And physically examination, there is no deficit or chronic deficit. And in case of stage B, that is moderately malnourished or suspected malnutrition, there's a 5% weight loss in 1 month or 10% weight loss in 6 months. There is no weight stabilization or gain. There's continued weight loss. And there is a definite decrease in intake. Uh, when we ask questions also, like sometimes when the patients answer, they sometimes they don't tell properly. So we have to, ask them means like, whether in this past 1 or 2 days or past 3-4 days before coming over here, were you able to take food properly or like you were facing problems. Then that is how we get the correct answer. The presence of nutritional impact symptoms, moderate functional deficit or recent deterioration. And there is evidence of mild to moderate loss of subcutaneous fat and or muscle mass and muscle tone or palpation. There is a severely malnourished patient. There is a 5% weight loss in 1 month or 10% weight loss in 6 months. There is continued weight loss. There's severe deficit in intake. Patient might be taking, either he might be taking liquid diet for maybe, more than 2 weeks or something. Whenever he tries to take food, he vomits. The presence of nutritional impact symptoms. There's a severe functional deficit or significant recent deterioration and obvious signs of malnutrition like severe loss of subcutaneous tissue and possible edema. So these are these parameters like I've already discussed before that, this about the albumin, prealbumin, and transferrin and the skin fold thickness. And there is the waist to hip circumference ratio where in males it is less than 0.9 and in females it is less than 0.85. And at risk for malnutrition, it is greater than 0.9 and it is greater than 0.85. The mid-arm muscle circumference in males it is 23 to 25 centimeter, in females it's 20 to 23 centimeters. In case of patients who are at risk for malnutrition, it is less than 21.1 centimeter and it is less than 19.2 centimeter. Next, we move on to hand grip strength. Hand grip strength is reliable and it is a simple marker of whole body strength. And there are different types of hand grip dynamometers available. We can use a hand grip dynamometer in the critical in the ICU, and it's a good evaluation tool that can be used to measure the hand grip strength to see the muscle strength. We can also check like means when the patient comes in, when the patient is admitted in the ICU, on the first day the hand grip can be measured, and even after 2 to 3 days after the nutrition started, we can again see the hand grip, check for the hand grip whether it is improved or not. Also, when the patient is getting transferred to the normal ward, again once more the hand grip can be checked, and when before the discharge also the hand grip can be checked. So that is how we come to know that whether the patient is improving or not. So these are the different assessment. That is subjective assessment is the CT image analysis, skin fold measurement, ultrasound muscle measurement, and hand grip strength is there, fatigue score is there, activities of daily life. That is whether the patient is able to perform the daily activities smoothly or not. There are many tools and methods for nutritional assessment, but we need to see which is the most practical and feasible. The practical methods, they can be adapted and developed. The metabolic status and nutritional status of the patient need to be assessed, and the calorie deficits must be avoided at all points. I would like to mention over here that in our ICU, they do the CT image analysis system. It is done when the patient comes in. It is also done every 3 days. So, and we do the subjective global assessment. We also do the NRS 2002 and the Nutrix score. And then we perform as a team. That is, we arrive at a consensus that, like how malnourished the patient is, how much the patient needs. And then as a team, we start with the nutrition, and we also check for the hand width and the this with the CT image, that is a intensivist, he can check the muscle mass and he can see whether the patient is being underfed, or whether the patient is means with whatever nutrition is being provided, whether it is improving, means whether it is helping him or not. So corrective actions can be taken. Thank you.
Mm. Tha- Thank you, Rajeshwari. It was quite an informative lecture. Um, Meenal, before we get into, if there are any questions, please put them in the chat box. But I'd like to ask you some questions based on the talk that you gave. So, in your ICU, are you using continuous nutrition all the time for critically ill patients? Because I did mention, I just see a slide in yours that said you use continuous nutrition to all patients in the intensive care unit.
So all the patients will end up having either intolerances or have a aspiration on the day of admission, or the patient who are like, if the patient needs prone position and those modes of ventilation, we do start with continuous drips. If the patient has been NVM for a longer period of time, and in case if there is any gut motility, all of these patients are started on a continuous drip feed. If it's a stroke patient with no other complications, then a bolus feed is started for these patients. Otherwise, the critically ill, we do start with continuous drip feeds.
So when you're doing continuous nutrition, you're using the use of feeding pumps, or is it gravity-based feeding? What are
Feeding
you
pumps,
actually
sir. We do have a feeding
feeding
pump.
pumps?
So we use an
Okay.
amica bag in a feeding pump, and we have a proper drip-based feeding method that we are using currently.
Yeah.
So we
So we are now in a situation where at least the PENSA and the ISPEN would recommend the use of GLIM criteria, because that is something that has been the language of malnutrition that we should all speak. From 2018, after GLIM criteria has come onto the onto the usual literature, we should be using GLIM criteria for the diagnosis of malnutrition. So Rajeshwari, are we still using GLIM criteria, or have we started moving towards SGA, or SGA has been moving towards? Are we still using SGA, using GLIM? What is the situation in the hospital with respect to intensive care and with respect to hospital patients in the wards?
So we are using the subject SGA, and we will slowly move forward to GLIM criteria. Yes, presently, we are using the subjective global assessment, and we are
So
using
I
the
did
NRS 2000. Yeah.
Yeah, so I did have a talk with a couple of dietitians recently, clinical nutritionists across the city of Mumbai, and I was surprised to see that a good 80% of clinical nutritionists involved in care of patients that are ill are still using subjective global assessment. Um, Meenal, what is the practice in your hospital?
So we are still on SGA. We have actually a screening tool that we have developed on the basis of an SGA. It's not just a complete SDA, it's a nutrition screening and assessment combined tool. So we've
Hmm.
modified the SDA in a way, and we've been using it for a while now.
All right, so it's a modified SGA, but
Modified SDA.
at least since we are on an ISPEN webinar, and since we as ISPEN have actually endorsed the GLIM criteria along with the PENSA and the ASPEN and the ISPEN, I think we all should make an effort to go towards the GLIM criteria, because if we all speak a same language of nutrition, then probably we would be able to progress on research future. Otherwise, what you call as malnutrition will be different from what I call as what Rajeshwari calls would be different. That's the reason that we probably should follow one single criteria. Well, there is a question from Mrs. Shabana Parveen. So what she's asking is, so I'll probably ask this to Rajeshwari, and Meenal, if you want to also answer, you can probably answer this. The question is, if you're assessing your patients in the intensive care units, what all points you would like to recommend to check in terms of nutritional recovery is happening? So what I understand from this question is, how do you assess whether what you're doing is doing good for the patient? So what would you do for that, Rajeshwari?
Yeah, to check like means we'll do a means follow up of the patients, and then like we take the hand grip. Okay, means like how I mentioned this when the patient comes in, we check the hand grip, and when the patient, with after 2 3 days, when we have given the proper nutrition, started the nutrition, then again we check the hand grip whether it has improved or not. And plus, the this intensivist will be doing the CT scan, and they will be checking for the muscle mass. So in that also we can see whether this by looking at the muscle mass, whether the this is improved or not, means whether it is the nutrition is helping the patient or not. And also this what to say. We can also look out for certain symptoms, like many a times a patient comes in, he is good enough and he's eating well, and then suddenly slowly, means like we can see some deterioration signs or something. Like we check like if the intake is 50% or less than that. So when the intake is 50% or less than that, then that is the time we start the supplement. And we have seen in many of the patients that when we start a supplement along with the food what is going to the patient, then the patient improves. He definitely improves, and we can see that, like he is getting transferred to the ICU at a faster rate, like because the nutritional supplement along with the food is helping.
Meenal, are you looking at any objective parameters that will explain that this patient is recovering from malnutrition? Is there something that you are looking at?
Um, Sir, ideally, we would actually work in coordinates in a team with the intensivist. So there will be many factors like if the patient is not being weaned off. So we would want to look at that. That is, does the patient have enough strength for him to be weaned off a ventilator? So that is when we want to relook at the calorie and protein feeding that we are doing. It is also the patient's physical strength. So like Rasheshwari explained, the physical strength is something we want to keep at. But for patients in ICU, we expect a bit of muscle wasting because of immobility. So that may not be a very clear criteria. But yes, if we're looking at RT feed, we look at the overall parameters. Weaning of ventilator is one of the major areas we would want to look at. And eventually, when the patient is started on an oral feed through an RT plus oral or something, we would want to look at that area of how is the improvement there. And when we talk about just feeds, then we look at the feed tolerance. In case the feed tolerance is good and the delivery of nutrients is good, we we would want to consider that the patient is tolerating the feeds and the overall progress, because at the end of it, it's a medical condition as well, that we matters on how well is the patient going to be recovering, or how well is the nutrition going to be assessed. The assessment
Right.
would also depend
So
on that.
yeah, so I got that. So what I would recommend, I mean, I would something that I do in the hospital is regularly is the fact that once your patient physically gets better, one of the ways you could do that is by looking, as Dr. Rajeshwari said, that hand grip dynamometer. With that, it is very easy to figure out whether the muscle mass is going up. But all said and done, every hospital does not have hand grip, and that's what Shabana is actually asking us. Shabana is asking us, hand grip is not available in every hospital, because when you say every hospital hand grip, when we talk about it, has to be the Jabbar hand grip dynamometer or an equivalent. It cannot be the plastic ones that you get otherwise. But yes, the hand grip is not available in every hospital, and CT scan is not done on a regular basis. So what do you do? So in this case, there is another tool called as the bioelectrical impedance analysis. The BIA is another tool that will probably help us to understand about lean body mass, fat-free mass, and the amount of skeletal muscle index that is going up on these patients. But more importantly, a clinical feature that you can actually look at very easily is whether the patient can sit on a chair. If the patient starts sitting on a chair and his chair up sit up actually increases faster and faster, you would probably get an estimate that a neutral recovery is doing some work. Simple things. If you make him sit on a chair and note down in 15 seconds how much time the patient can go up and down, even if he can go out once, that is very big for for an ICU. You know what is very big for an ICU. Though we say 5 is what is recommended in the first 12 seconds with this chair sit up and sit down test. Well, there's another question that comes in from Shaban. Is that if it's okay with that answer, or do you need something more on that? Please feel free to put up again. So there's one more question that has been asked by Nikhil. How do we find calorie requirements of a particular patient admitted into the intensive care unit if we don't have indirect calorimetry? So, Minal, we in our hospital have indirect calorimetry, and we've been using it on a regular basis. So, how would you do it accurately if we don't have indirect calorimetry, and what would be the way you would do it?
So what we are currently doing is first taking the estimating or calculating the total requirement of the patient, that is based on the formulas given by ISPEN. So for critical patients, 25 to 30 kilocal per kg body weight is the formula for energy, and for protein it's anywhere between 1.2 to 1.5. On a very severely undernourished or patients with higher metabolic requirements, we go as high as 2 gram per kg present body weight. These are the cases where we have something like GBS. So otherwise 1.2 to 1.5 is the calculation for proteins per kg present body weight, and 25 to 30 is the total requirement of calories, 25 to 30 kilocal per kg present body weight. Again, specific cases may need interventions, but we would start with 70% of the initial requirement and then progress to the full strength on the third day. We do not start with the same thing on day one. So we start with 70% or a lower in case if the patient is on a smaller drip or on a smaller volume of a feed. So if it's somewhere around 20 ml per hour or just 50 ml per 2 hourly, if that is the strength, then we may be at a lower strength. But as in how the volume progresses, do we progress the feeds to a full strength feed over a period of 2 to 3 days? So we're using
Right. So
kg based formulas.
yeah, so what we can understand from what Meenal said is that if you don't have indirect calorimetry, the way to do that would be using simple predictive equations that have been actually put up by the European Society and the American Society. The American Society actually says the lower version, whereas the European Society says that the highest 20 to 25, 25 to 30. So on an average, 25 kilocalorie per kilogram is what it looks like. But just to put this in a little bit more objective way, I can give you one more way to do this. Okay, that is if you have a EtCO2. Usually patients who are in the hospital have got something called as end-tidal carbon dioxide. If they are ventilated, they have an EtCO2 monitor that is placed. Now this EtCO2 monitor is the carbon dioxide that is produced in end tidal at every time that is there. It is there on most of your ventilators and most of your patients that are actually in the hospital in the ICU. So in that case, you can actually calculate the resting energy expenditure by multiplying your VCO2 with 5.5 into 1440, which is just the modification of the Weyer's equation. So by just doing 5.5 into VCO2, which can be derived from the EtCO2 into 1440, you would actually get the energy expenditure objectively. So all those people who don't have indirect calorimetry, the second best option would be to actually figure out energy expenditure using VCO2 equation, which is nothing but a modification of the Weyer's equation that we use for indirect calorimetry. And then if this EtCO2 is also not there, then it would make sense to actually go ahead and do simple predictive equations. So by definition, measuring is always better than prediction. And we know 25 to 30 is after all a simple predictive equation and not really a measurement.
Sure.
Right. So there is another question. Any questions on this, Meenal, Rajeshwari? Any questions on anything you want to add on to this that I just now said? No. All right. So there's another question that is asked by Veena. How about parental nutrition in the ICU care, checking electrolytes? Do you check electrolytes? I think Meenal has already answered that question that yes, you need to check electrolytes and accordingly we should actually be modifying your nutrition accordingly. But Meenal, tell me one thing. If you have a situation where there is a hypokalemia or say a very low potassium, can you modify this by feeds or is you require external supplementation? Can you modify it by just feeds?
So just depending on what is the potassium level. Now there are certain formulas which are high in potassium. That is how we play around with nutrition. So there are certain formulas which are very low potassium, and there are certain formulas which may have a higher potassium content. We may try and modify the beats based on those formulations in case if there's a need. But a potassium correction may be needed because it may not meet the requirements of the patient. If the patient is
Absolutely. So
severely
what
hypokalemic.
Meenal says is very important that hypokalemia has to be treated by external supplementation, and a diet may not be adequate enough that it can replace the amount of potassium that is required. Um, yeah. So, Rajeshwari, let me come back to you on assessment technique. Have you done any kind of study that actually looks at recovery of muscle mass after nutrition? And have you followed that up in any way? Is there any study that you have done that explains us that if you give nutrition, these patients do well at a later date or something like that? Is there something you have done with hand grip telemetry in the
Yes, sir.
assessment of
Yes,
recovery?
sir. Yeah.
And what was the findings of your study actually?
So we noticed that like means we had formed a nutrition support team, and we were checking the hand grip also. And this after doing the assessment, we were means we arrived at this that came in this much calorie this much protein is to be given. And when the feeds were started, then after day 3 or day 4, again the hand grip was measured, and again this after transfer from ICU and before discharge also, the hand grip was measured, and it was seen that there was an increase in the hand grip. And also, the patients were followed up after 1 month after post discharge. Like they were means those who were able to come to the ICU, they were called in the ICU, and again their weight was checked, and the hand grip was also checked, and we could see that there was a definite improvement. There
So
was
what
an
this
increase in
what
weight
I
also.
Yeah, so what I hear from Meenal and Rajeshwari together is that it needs a coordinated effort by a nutrition support team whenever we are dealing with nutrition in any individual. And since this is one of the common elements that we do to all our patients who come into the hospital and into the ICU, nutrition is a common element that is common to the treatment of any patient that is over there. I think that's one of the key to improvement in these patients. Very clearly, we can now assess whether these patients do recover. And it's great to actually figure out whether these patients do well. All of us doctors, I don't think can do better unless the nutritionist and the doctor works together. It's not possible otherwise. Thank you, Rajeshwari, for this informative talk that you gave on assessment of nutrition, and thank you, Meenal, for actually enlightening us with all that we have in critical care. And we will look forward to more of these webinars so that we can actually exchange knowledge. And thank you to whoever have joined in for this particular webinar. And for all those who haven't joined in, it would be available on YouTube on the ISPEN YouTube channel. So please join the YouTube channel to hear this webinar. Thank you very much. Thank you very much.